Okay, well, good afternoon. I'm Cristian Villegas. I'm the nurse practitioner here with Dr. De Rosario's clinic up in North Palm Springs. We do work for Eisenhower. Our population are mainly HIV positive patients, PrEP patients, and transgendered. Today, I'll be discussing some two medications that I'm been dispensing left and right that have made a huge difference in the sexual health of our patients, who are mainly gay men, but also transgendered and some little old ladies as well. So let me try sharing my screen. I'll try running through my presentation. I'll be talking about both topics, and then I'll save some room for questions at the end. Again, this topic is going to be on PrEP, pre-exposure prophylaxis against HIV, particularly when it involves barebacking or no condom use. The fact is, it's become pretty prevalent in what I call the gay ghettos, Palm Springs, San Francisco, all the major cities that have a large gay population. They all seem to be on PrEP. Everybody's on PrEP or undetectable. And with that in mind, most people are barebacking. But as soon as you step outside those cities, you get back to a lot of people who don't get tested, who are not on PrEP, and who are likely unknowingly HIV positive. So the important thing to remember that this is targeting HIV. Amazingly enough, there are still 1.2 million people in the US who are affected, and I was flabbergasted because 87% of those people don't know it. The majority of cases are male to male. There have been some, of course, heterosexual interactions, and some have to do with IV drug use as well. A particularly important point is that there is a huge discrepancy. It does seem to target young African gay and bisexual men. And as you can see here, other minorities are affected as well, Hispanics, and African American women. So in these gay cities, it's the general consensus that HIV is not a big deal because it's so well controlled, but we have to understand that as soon as you step outside that comfort zone, particularly in all the red states, Texas, Florida, they are trying to pass laws to prevent PrEP medications from being dispensed, and they even try to prevent HIV medications from being dispensed. So try to help out those that don't have access. And like I said, there is a huge disparity. Black, Hispanic, and other minorities are mortally affected by HIV, and may only be having it. There is a national allocation for money to try to fight the HIV pandemic. As you can see here, every year, the president asks for a certain amount of money to try to end the HIV epidemic. The goal is to have 50% of those who would benefit of the 1.2 million by 2025, but we're still only at about 30%. Optimistically, the CDC does shows that certain financial barriers to PrEP have been reduced, and I'll talk about some of those in just a little bit. The Obamacare, it does include PrEP meds and services to be covered. But as I said, a lot of those red states are trying to do away with that and set us backwards. So PrEP, the first medication was Truvada. It was approved in 2012. Again, 1.2 million could benefit. Steadily over the years, more and more people have been prescribed, and we're getting closer and closer to the 50% gauge. Again, underserved populations include African Americans, Hispanic population, transgender women. But the great news is when taken appropriately, and this is taken daily, it does have a 99% protection on sexual contact. It seems to be slightly less effective in injection-used transmission, but right now we'll focus on the sexual transmission. Non-scientific notation, Dr. Derzari has been an HIV expert here for several years. And in the 2 years that I've been here with him, we've only ever had 2 people convert to HIV in the last 10 years, according to him, which I thought was pretty amazing. One was a patient that was trying to make his PrEP last longer. He has lost his insurance and was trying to make it last. And unfortunately, when not taken daily, that effectiveness does wear out. And another one was an older gentleman that swore to us that all he ever did was oral sex and he never barebacked. And we hadn't tested him for about 2-3 years. And then he decided that he wasn't going to bareback and wanted to start PrEP. And we tested him for HIV and he was positive. The good news is that it's no longer a death sentence. It's now just considered another chronic disease, and we do have some very effective medications that can be safely taken. And HIV patients can live a long and normal life. So, what exactly is PrEP? You know, it comes down to, again, in these cities where it's prevalently gay men, it means that you can't have sex without barebacking. I mean, without condom use. There are a lot of myths about it. How much does it cost? It's only for gay men. Other things are they think because they only play with down low guys that they're not at risk for getting HIV. So there's still a lot of myths involved, and one common one that I actually see from new PrEP patients that I see in my clinic that came from other doctors in the area or outside the area is that they actually do tell them, like, hey, they don't know too much about it. Why don't you just not have bareback sex? Why don't you just use a condom? And some of them are actually slut shamed into feeling bad about wanting to go bareback. So PrEP does include taking a medication to prevent the transmission of HIV specifically. Right now, there are 3 approved versions. The oldest one, of course, is Truvada, has been around for a long time. It is available as generic. The newer, more kidney-friendly version is Descovy. And just in the last year, there's now Apretude. That's an injectable every 2 months. All of them have their pluses and minuses, which we'll go into specifically. Our clinic only prescribes the first 2. I'm only aware, I think some places at the AP do Apretude, and the infectious disease specialist over at Eisenhower, Dr. Gaultier, he does Apretude. But the main thing is, if insurance is going to pay for it, they're going to want to know, why is this patient not taking the generic? Why is the patient taking the expensive oral? And why are they taking the injection instead? Because cost is very, very expensive between the 3. We'll talk about each one specifically. Again, Truvada has been around the longest. Generally well tolerated. Some people can get nausea and vomiting. If that nausea and vomiting doesn't go away, that could be a clinical indication to switch them to Descovy, which I've often done. Main concern with Truvada is that long-term use can be seen to affect your kidney and your bone health. You do need a filtration rate, a measure of kidney function above 60 in order to be prescribed it. And if I see patients who have been on Truvada, and if I see that over time they've had a drop of their kidney function beyond 20%, even if it's still normal, I can switch them over to Descovy. Something that is very important that I try to point out to my patients is that taking Truvada by itself is usually not a problem, but if they are taking other things that challenge their kidney function, specifically anti-inflammatories, and then the other thing is just chronic dehydration. If people don't drink enough water, that 1-2 punch of Truvada and dehydration can often affect their kidneys. And I have had some people who had that happen, and I had to switch them to Descovy. Again, both oral medications have been studied for daily use with their effectiveness up to 99%. PrEP on demand or different versions of it, those are mainly seen in countries where cost and access are more of an issue. in the United States. The FDA does not promote that because the effectiveness can drop down as low as 88%. So Descovy, once Truvada fell out of patent, they came out with Descovy, which is a kidney-friendly version and does have its benefits, but to be honest, it was also a little bit more of a money grab. So it's less likely to have GI side effects, but I have had patients who were started on Descovy and their insurance wasn't happy about it, and we switched them to Truvada, and they actually tolerated better. So it's very much depending on the individual makeup. Less likely to affect kidney health, less likely to affect bone health. You do need a filtration rate of 30 as opposed to 60 to be prescribed this, but you should still avoid chronic anti-inflammatories and also chronic dehydration, because again, it can affect your kidney health. And Descovy, same thing. It's recommended for daily use, not intermittent use or as needed, since the effectiveness can drop off significantly. Apretude is another new medication. It is an injectable. The thought is that instead of having to take a pill every day, you would just get an injection every 2 months, which does sound appealing, especially on the patient side. Certain things have to happen beforehand. The most important is you want to make sure the patient is not allergic. So providers usually provide an oral version of that medication for 28 days to make sure there's no allergic reaction, because the last thing you want is to inject somebody with a medication that you can't get out of their skin that they're severely allergic to, that could actually be life-threatening if they have anaphylaxis. Other side effects are irritation injection site. It can cause some liver toxicity, and in various ways it can cause GI symptoms like diarrhea, GI upset, abdominal pain, and some studies have shown that it can actually increase depression. So that's something you would need to assess regularly. The injections are every 2 months. You do have a bit of a leeway. You can do it 7 days before or after the due date of the original schedule, but something that patients are not aware of, that the clinical side is aware of, is that it sounds very convenient to only need an injection every 2 months, but with our PrEP patients, sometimes it can be challenging for them to come in every 3 months. So having them come in sooner, depending on the patient, that could be challenging itself. And with this medication, it has to be stored under very, very specific conditions. It has to be thawed within a certain amount of hours before it's injected. And if the patient misses that appointment, whether they're sick or they miss their bus or for whatever reason, that's a $3,000 medication that goes to waste. And who gets to pay for that? Does the patient get footed with the bill? Does the insurance get footed with the bill? Or does the medical provider? So those are reasons why Dr. Rosario and I have not jumped on the Apretude train. Another reason why he feels it's not quite the time to jump on that is that he suspects there's going to be a 6-month version injectable PrEP that should be coming out within the next year or two, and he thinks a 6-month schedule as opposed to a 2-month schedule is a bit more realistic. But Apretude can be given safely to patients with kidney and bone issues. You do want to be careful about drug interactions that can lower the effectiveness and possibly leave the patient to be exposed to HIV. These are some common anticonvulsants and antibiotics. Again, it sounds great that you have no pills, but the insurance will need a reason as to why is it that we are paying, instead of paying for the generic, why are we paying for this super duper brand new expensive? And usually you have to substantiate it. If the patient has kidney problems, if the patient has oral problems and can't swallow pills, you may be able to approve it, but you really have to build a case for that. So as far as patients considering for PrEP, again, gay men who have sex with men and bareback, heterosexual men and women should also be considered, and of course injection drug users, because there is that blood-to-blood transmission of HIV. The requirements before starting, every time I get a PrEP patient, I have to make sure A, they're HIV positive, B, I want to get a baseline of their kidney function, C, I want to make sure they don't have any active hepatitis B infection, because Truvada Descovy can affect that, and we don't want to build any resistant strain. An important point here is that you do want to have access to HIV care. You know, if a patient happens to be on PrEP and somehow they do become HIV positive, you would want to make sure that they have access to a provider that can help them bridge that. There are different criteria for kidney function, as we talked about earlier. We talked about the Hep B status, and you don't want to make sure you're not on certain medications that could complicate it. Specifically with Truvada Descovy, no Hep B infections or medications for Hep B, and then the other medications for pancreatic cancer. And we talked about the other medications that could affect amplitude. So once you start PrEP, you want to make sure you take it daily. I usually see my patients every 3 months and have labs done about a week or two before, so we can make sure that they're HIV negative and make sure they're taking it daily. We want to do STD testing based on their sexual exposures. For my clinic, we test for HIV and syphilis every 3 months, and I'll tell you about that in a minute. And we test for gonorrhea and chlamydia based on sexual exposures. So a couple of other things, like I said, we do test for STDs based on activities. For IV drug use, that is a good idea for them to have access to clean needles and syringes as well. These are the actual guidelines in case for any clinical providers that are interested in how to provide those medications. But what if PrEP fails? Again, we've only had it happen twice here in our clinic, but I'm sure it's happened other places, and it's usually a compliant issue. Most cases where people did fail PrEP, when they checked on the therapeutic levels of PrEP in the blood, it wasn't quite adequate, meaning that they weren't taking the pill daily. So if somebody does become HIV positive, again, I've only had that happen once here, HIV treatment, and instead of taking a PrEP medication, they're taking an HIV medication. And today's regimens are usually pretty simplified. We can usually start them on something like Biktarvy or Triumeq, and it's just taking one pill once a day, and it's no longer as liver toxic or kidney toxic as the other medications that I'm sure a lot of you remember. So of course we'll get a CD4 and viral load, and have them follow up regularly to make sure that they become undetectable and their CD4 goes back up to normal. We do genotype testing to make sure we don't have any resistances before we prescribe, and we continue to counsel them on sexual health. Some people talk about, well, you know, if you put people on PrEP, that increases sexual risk taking, but actually, the IPREX studies show that there was actually a decrease in sexual risk taking during the study period, and the PROUD study showed there was no significant difference in STD test incidences compared to the base group. So PrEP will substantially reduce the risk of contracting HIV only, but what about the other sexually transmitted diseases, syphilis, gonorrhea, chlamydia? And as you can see, there's a bunch of others that are not quite as common, but still a possibility. So what can we do about that? Well, that's where DoxyPEP comes in. So DoxyPEP is doxycycline for post-exposure prophylaxis against other STDs. That doesn't mean that you take it before you have sex or the day you have sex. You usually want to wait about 24 to 72 hours to taking it. And this does, the important difference is that this is in addition to taking PrEP for my patients that bareback. But I do have patients that, you know what, they don't want to deal with HIV, they don't want to deal with PrEP, but they still like to play, they still like to get sucked, they still like to be sucked, and that means they're still vulnerable to a lot of these STDs, and that's a specific population that I still encourage them to do doxycycline post-exposure. So as far as those specific STDs, we do have 1 in 5 in the US that are affected by STDs. Ages 20 to 34 have the highest rates. HPV is actually the most common STD. Just about everyone has it. It's very easily transmitted and it's usually asymptomatic. You still want to get tested. You want to make sure it doesn't progress to rectal cancer. And if you are of the appropriate age, you want to get vaccinated. Chlamydia is the second most prevalent, followed by gonorrhea and syphilis. Of an interesting note, California has 801 STDs per 100,000 in population, and those STD rates are highest in Mississippi, Louisiana, Alaska, South Dakota, and South Carolina. So you really gotta be careful with those southern boys. As far as chlamydia, a little bit of information, most important of which that I try to teach my patients. Most people will not know they have it. Oral and rectal chlamydia is usually no symptoms. You can still spread it. It can still affect your fertility, particularly in women. It could cause pelvic inflammatory disease if not treated appropriately. Urethral, for both men and women, you will usually have light discharge and maybe some burning while you urinate. The symptoms can appear anywhere between 1 to 4 weeks, but usually you'll see within 7 days. Treatment for chlamydia, first line is doxycycline 100 milligrams twice a day for 7 days. If somebody is allergic to doxycycline, which I have a handful of patients that are, we need to give them 1 gram of azithromycin as one dose, a one-time dose. For gonorrhea, again, most people will not know they have it. Oral and rectal, again, is usually no symptoms. You can still spread it. It can affect fertility. Urethral, you will have heavy discharge. So anytime I have a patient that comes into my clinic and they tell me like, yep, it's just burning, it's just heavy discharge, I usually still test them to make sure, but I will treat them empirically for gonorrhea because that's the one most likely. I have had patients that, you know what, I just feel this funny burning. It burns every once in a while, and sometimes it hurts, sometimes it doesn't, and then I'll test them, and it's actually chlamydia. So it's usually pretty easy to tell between the both. So the treatment for gonorrhea is a one-time shot of ceftriaxone. We usually have to do that in the clinic. You can't do that yourself. If somebody happens to be allergic to ceftriaxone, I don't think I've ever had this happen. You can use an alternative injection as seen here. Syphilis. So again, most people will not know they have it. So do you see a pattern here? 3 of the most prevalent STDs, and it's very easy to not know that you have it. Syphilis does come in 3 different forms. Primary is a painless ulcer. If it's for a top, it's usually anywhere on the shaft, maybe on the scrotum. For my oral guys, for my bottom guys, it may be in their mouth, it may be in their anus. And the key thing is that it's painless, so they will not know they have it. I had a patient that came in. He had all his PrEP labs done, and I told him, well, you're HIV negative, your syphilis is negative, everything looks great. He's like, oh yeah, what about this? And he whips it out, and he's got this big old sore right on the head. And I'm like, I just went and touched it. I'm like, did that hurt? He's like, no. I'm like, that's syphilis. He's like, yeah, but my test was negative. So what a lot of people don't know is that primary syphilis is usually, you can't test for it. It can take up to 2 months for syphilis to show up as positive on the standard test. And by then it may be too late. So whenever somebody is exposed to syphilis, we don't test, we just treat accordingly. But that ulcer, wherever it may be, it usually goes away. Eventually it can become secondary syphilis, which is usually a painless, an itchless rash. Can be just about anywhere. We're often taught that it's in the palms and the feet, but it's not always the case. I had one of my elder gentlemen, he wanted me to look at his hernia, and I had him take his shirt off. And when he took his shirt off, he just had this big old rash across his chest. And I'm like, what is that going on there? And he's like, I don't know. I thought it was maybe a sunburn. And I'm like, does it itch? He's like, no. And then we checked his RPR. by the time it reaches the secondary, it will affect his titer and it will show as positive. And sure enough, he was in full-blown secondary syphilis, so we had to treat him. So that in itself can come and go, and eventually can become tertiary, which it can be in your brain. Of particular importance is that secondary to tertiary usually takes weeks to months, but Dr. Derazar has taught me with our HIV positive patients that can happen sooner rather than later. So with an HIV positive patient, they may have secondary syphilis and it can quickly become tertiary syphilis or emergency. So that's why with our HIV positive patients, we check them every time we see them because we certainly don't want to miss that. So tertiary, as I said earlier, it does lead to brain symptoms, neurological symptoms that can lead to slurred speech, lack of muscle coordination, paralysis. Treatment, the first line treatment for syphilis is a one-time shot of penicillin if we have a recent negative syphilis test. If it's been 6 months or longer, that can be, or if the titers very high, that can be considered syphilis of unknown duration, and it would be 3 shots of penicillin, each given a week apart. If somebody is allergic to penicillin, we can give them doxycycline for 7 days, and I've actually had the health department tell me how to treat some of my syphilis patients because there was a shortage of penicillin, and one of my patients had to take doxycycline for 28 days. So for the doxy-PEP, as hopefully you saw earlier, the reason why doxycycline is so effective at preventing STDs is because it's first line for chlamydia and it's second line for syphilis. So as you can see here, when you take a single dose of 200 milligrams, 2 pills taken within 24 to 72 hours after condomless sex, there's a significant reduction in STDs. The slash is comparing PrEP patients and HIV patients, and as you can see, chlamydia, 88 to 74%. Gonorrhea is the least effective, 55 to 57%, and syphilis, 87 to 77%. So there is that window of opportunity, and I try to teach my patients, we don't want you taking doxycycline all the time. At the most, take it every 3 days, and if you take it every 3 days, it should cover you for the previous 72 hours. So it's still very important. This is not 100% proof. You still want to get screened every 3 months. The official recommendation is if you play for 3 days and take another third day, if you have sex again, you're supposed to be taking it another dose within 24 hours of the 200 milligrams. But I've been prescribing this for about 4 months, and I've had patients that went on extended play vacations. One went to Lazy Bear, and he did everyone and everything there. He took doxycycline every 3 days, and he came back, and I tested him, and he got nothing. I had another patient who went to Berlin and Sitges for 2 weeks, and he's like, I've never had more sex in my life. I know I picked up something. And we tested him, and he was perfectly fine. And I don't think it's just that that my patients were on doxy. I think that this has been around long enough that a lot of other patients or people out there are also on doxy, and that's generally keeping STD rates down overall, which is conveying a sort of herd immunity, which I'm very happy with. So you want to make sure you take with a lot of water. Make sure if it upsets your stomach, you can take it with food. You want to avoid dairy, calcium, antacids, multivitamins within 2 hours so the absorption is not reduced. It can make you photosensitive. So you want to make sure you use sunblock and protect your eyes. You want to encourage good bacteria, yogurt, and or probiotics. A question that I'm often asked is about resistance. If we take antibiotics all the time, is that promoting a resistant strain? So we have not seen any resistance to STDs or STIs, but it can lead to resistances in other pathogens. So if somebody gets a pneumonia, if somebody gets an abscess, if somebody gets some other kind of infection while they've been taking doxy, it's a pretty sure bet that they are resistant to doxy, so I would have to look at other medications to treat them with. And of utmost importance is that this is not for everybody. We really want to have a joint decision making between the patient and ourselves. For myself and Dr. De Rosario, we try to tell the patients the pros and cons of doing something, not doing something. But at the end of the day, we're here to support them and help them to reach the decision that's best for them. Whether or not we agree with it, it's up to them. But it's really all about supporting them and their care. So I'll leave this for any questions for me.
All right. Yes, we actually have one question in the chat, and then we'll open it up as well. It says, if PrEP designed to prevent transmission from a positive man or to prevent a negative man from becoming infected?
So PrEP is designed to keep people HIV negative. So I do have discordant couples where one is positive and the other one is negative. And I would encourage you to look into the U equals U or undetectable equals untransmissible. So we have never had any of our HIV positive patients who are undetectable transmit HIV to anyone. So positive patients who are undetectable, it is statistically impossible for them to pick up for them to transmit HIV. PrEP is to protect HIV negative patients from getting HIV. Now, if it's I do have monogamous couples where one's positive, one's negative, but as long as the other one's undetectable, they do not need to be on PrEP. But most often, my couples will have one positive, one negative, and they also play outside the relationship. So we do put the negative patient on PrEP to protect them from getting HIV from somebody else outside their partner. In the U equals U study, they studied several thousand exchanges between discordant couples, and they did not have any HIV transmission from their partners. Some of the negative patients did become HIV positive, but when they studied the genome and compared it to their partners, it was a different strain. So their partners got HIV from somebody else, not from their positive partners. I hope that answered the question.
Great, thank you. We have no more questions in the chat, but let's open it up to anyone in the here online. If you would like to unmute yourself, please do so and ask a question of Cristian, and we can get some answers for you. No question is unheard, so please feel free to ask what's explicit or whatever you would like.
Yeah, I hear everything from my patients, so you're not going to embarrass me.
So I guess a question that came up from a friend who traveled recently abroad, he had been given doxy PrEP before he had gone on vacation, thinking that he might go out and have some fun. And then he had one individual who he played with, and then when he came back, he had told me that he had taken his whole regimen of doxy. So he had a one-night activity over a course of a very long vacation, and then because he wasn't really cognizant on the dosage of what he should be taking. So I guess that's some clarity that would be helpful to understand. You know, in a situation like that, do you take 1 or 2 pills over 72 hours? Do you take the whole 7 to 10 day cycle? What do you recommend?
So in order to doxy PrEP, the way it's designed is you want to take the minimum effective dose to get the maximal effects. We do not want patients taking doxycycline every day. That would be a treatment dose. If somebody say like, hey, I was told I was exposed to chlamydia, but I don't have symptoms yet. If you likely were exposed, you would take the treatment dose of doxycycline, 1 pill twice a day for 7 days. We generally don't want patients taking doxycycline that long unless they're actually treating something. So There have been different iterations of DoxyPEP throughout the years. I remember a couple of years ago, the recommendation was to take doxycycline every day that you're playing for 7 days afterwards, which is a lot of antibiotics in your systems. But the current iteration is, again, the minimal effective dose with a maximum benefit. So we recommend taking 2 pills, which is 200 milligrams, which is the max dose of doxycycline in a 24-hour period, within 72 hours after condomless sex. So the example that I've been giving for months is I've been prescribing, like, hey, it's Pride weekend and there's going to be a lot of fun going on. So if you hook up Friday, hook up Saturday, you hook up Sunday, Sunday night, you take 2 pills of doxycycline with dinner, and that should cover you for the previous 72 hours.
Great, very clear. Thank you. And so please feel free to ask a question. I see someone unmuted. Feel free to ask.
Yeah, I'm hypersensitive to drugs. So in the protocol for the COVID, I took some antivirals and I blacked out for like 40 minutes. So I don't think I'm a candidate for what might I be a candidate for?
So antivirals and antibiotics are target completely different and go along different pathways. So I don't think because you took Paxlovid or any other COVID medications, I don't think there is a direct correlation between taking that and being sensitive to, say, doxycycline. So have you ever taken doxycycline? Have you ever had a skin infection? Or have you ever had chlamydia?
No, but I can tolerate antibiotics.
Right. So again, this gets back to, we want you taking the minimal effective dose. We don't want our patients taking doxycycline every day. I do have patients, my adult performers, my OnlyFans guys, uh, on their own, they take doxycycline every day because they have sex every day, so they want to prevent STDs every day. But those patients, when they get a pneumonia, I had one that got a huge abscess in his scrotum, and of course, when I tested it, was resistant to a whole bunch of different medications. I had to put him on IV medications. So we don't want you taking antibiotics every day, but I would encourage you to talk to your provider, see if you can get like a test dose of doxycycline. I have a handful of patients that think they have an allergic to doxycycline, but they're not sure, and it's not anaphylaxis. So I'll usually give them 1 or 2 pills and have them take it. If they have a little bit of itching, they can take some Benadryl. But some of them do well with it, and like, oh, it turns out I'm not allergic. So this is very, very individualized. So again, I would encourage you to talk to your provider and see if you can take a test dose, make sure you have some Benadryl and a friend next to you to see how you tolerate it. Because ideally we would only want you taking it, the 2 pills, maybe once or twice a week.
All right, thank you.
It would be
Other
like on an
questions?
as needed basis then.
Yes, it's not every time. Well, the other thing that I want to differentiate, if my patients are playing with their partner, of course they don't need to take doxy. If my patients are playing with regular buddies that they talk to regularly, and if either of them show symptoms, they would tell each other, that's considered pretty low risk. But if you're playing with somebody, particularly on a very popular weekend like the next 2 weekends, even if it's one of your regular buddies, if they hooked up with somebody, then that means you hooked up with them, and so on. So on high risk weekends or events, I would still encourage you to take the 2-doxycycline. But if it's just you and your buddy, and that he hasn't messed around with anybody else, and he's got no symptoms and hasn't messed around with anybody for a while, then there's no clinical indication for that. You just got to look at the picture and evaluate your risk.
Thank you.
Of course.
All right, other questions? Feel free to unmute and ask. You have a couple of thumbs up. Informative presentation. Thank you. All right. Any other questions? Anything from Candace on your side, from things that from past or present?
Yes, no questions, but thank
Okay.
you. And it was great having you for your first time here. I think you did a great job. So thank you very much. Very informative.
To give you some non-scientific studies of how effective this has been for my clinic. In June, I had 26 positive chlamydia and gonorrhea cases, and none of them knew they had it because, again, it's usually no symptoms. I started prescribing DoxyPEP, and in September, I still tested just as many people, if not more, but I only had 3 gonorrhea cases. So huge drop in STD rates, and particularly those high risk events and scenarios. My patients seem to be doing well with that, and I'm very happy with that.
That's fantastic to hear. All right. With that in mind, if there's no last question that someone has just been kind of waiting to ask, please feel free to unmute. But if not, we will say thank you, Cristian, for a very informative presentation, and it's perfect timing for leading into all the activities coming up in the next few weeks. And hopefully that doesn't mean that you're going to be working overtime at the clinic.
All right. Well, thank you very much for having me. And if you have any questions, just try to have them email me. I'll do my best to answer them.
Great. Thank you all so much. And we'll talk to you very soon with another presentation. Thanks,
Okay.
Cristian.
All right.
Thank you, everyone.